Hi, everybody, and once again, a good evening to each and every one of you who have logged in today to be with us on this very, very special 31st episode of 4D. And today, to be very honest, we're going to talk about something which is very relevant to each and every one of you out there, a topic which is very close to our hearts because Ramadan is just a week away. Ramadan starts exactly a week from now. And as we all know, as clinicians, we are all making preparations to help our patients fast better. We are trying our best to adjust the medications, to give them pre Ramadan education, to stratify their risk as to whether they can fast or they cannot fast. And to talk about this very, very interesting topic, I have somebody very special, Dr. Rukaya Surya Sheikh, who is actually in clinical practice handling a number of patients who are going to be fasting during Ramadan. At this point of time, to be honest, all of us are overworking so that we can help our patients fast. She is a diabetologist and director Blue Circle Clinic with practice in Mulund West for the last 11 years. A fantastic diabetologist, has done her diabetology from Nair Hospital and is a member of a number of clinical trials, a number of research, a huge amount of research, and a faculty and speaker at a number of conferences in diabetes. It's going to be great listening to you, Rukaya, and over to you to understand better from you how we can help our patients fast during Ramadan.
Hello, everybody. I'm Dr. Rukia Surya Sheikh, practicing diabetes and thyroid specialist at Mulund, and we are going to be talking today about diabetes and Ramadan. Ramadan starts this year on 23rd of March, and in India, we know that around 1 in 11 adults is living with diabetes, of which 1 in 2 adults is actually undiagnosed that he has diabetes. The number of people with diabetes in India is second highest in the world, and 40 million of adults in India have impaired glucose tolerance, which places them at a very high risk of developing type 2 diabetes. The reason why one develops a type 2 diabetes is a complex interplay of socioeconomic, demographic, environmental, and genetic factors. And in according to the 2021 census, around 140 million Muslims will be fasting for this holy month of Ramadan. So this holy festival, basically the fast is from dawn to dusk, where the patient observes fasting by not eating and also by not drinking, and it is associated, therefore there is a marked change in their diet. And also, after the fast during the day, there is feasting in the evening, which leads to erratic eating patterns. It disrupts the daily fasting feasting cycle, will eventually disrupt the glycemic levels of an individual. So, the question here today is that if a person has diabetes, should it, can he fast? One, and if it can fast, does it come at a price of good health? So the management of diabetes becomes extremely important during this holy month. What is this pathophysiology of fasting? How does the body mechanics change when a person is fasting? For an individual who's not a diabetic, so when he eats, there is increase in the insulin production, which promotes accumulation of glucose in the liver and muscle as glycogen. So, therefore, when he is fasting, the insulin production goes down when the blood sugar levels go down. However, when the patient is diabetic, the circulating glucose level tends to fall, leading to the decreased insulin secretion. But on the other hand, there is also the increase in the level of glucagon levels and the catecholamine levels, which starts increasing, and they tend to break up the glycogen stores which are present in the liver. So after several hours, these glycogen stores become depleted, and there is very low level of insulin which is present in the body, and therefore there is also increase in the fatty acid release from the adipocytes. So the fat cell starts breaking down, and there is release of fatty acids. Now, when this fatty acids release, this leads to production of ketones, which becomes the fuel for the skeletal muscle and the cardiac muscle, because the body is trying to reserve the glucose for the use of brain and the RBCs. And therefore, there is this breakdown which is happening in the fasting stage. So the difference in this in patient who has diabetes is there is an excessive glycogen breakdown which doesn't happen in a normal person, and there is ketogenesis which starts happening, and both of them tend to push the patient into hyperglycemia. So even if the patient is not eating and he's fasting, because the glycogen reserves in the body are breaking down, the patient is pushed into hyperglycemia, and there is ketoacidosis in the body. So the challenge which occurs in the diabetes management is we are most worried that the patient should not be pushed into such kind of hyperglycemia, but more so we are also very scared about patient getting hypoglycemia. We do not want any patient to suffer hypoglycemia when he is fasting, because the patient does not drink water during Ramadan fast. There are great chances that the patient might develop dehydration, and all of this pushes the patient to develop diabetic ketoacidosis. Patients who are taking insulin and also oral anti-diabetic agents, if they do not adjust their dose, then these risk of complications do increase. And during fasting, there is not just physical changes, but there is also mental health changes which occur, especially in elderly patients, especially in comorbid patients, and that pushes them to a significant risk of complications. The sleep cycle gets absolutely changed because the patient wakes up early in the morning to have his food. The food timings differ. So therefore, because of this irregular food habits, patient either skip their usual medication dose if they are not adjusted to a twice daily meal. And also the monitoring of the diabetes complications is delayed. The blood sugar is not monitored, especially in the rural areas, and that poses more risk of complications in terms of hyperglycemia, hypoglycemia, diabetic ketoacidosis, and dehydration in patient with diabetes. So what does one need to do is pre-Ramadan. So ideally, this would be counseling and proper adjustment for fast 1 or 2 months before the onset of Ramadan. But even now, today, we get patients a week prior who want to answer two questions. One, can I fast? And two, the question remains, what should be my medicine alterations when we fast? So to give the answers to both these questions, you need to review the patient in terms of his blood sugars, his HbA1c, his blood pressure, his lipid levels, and also complications that the patient is already having, or you expect the patient to have these complications because of very high blood sugar. So this is an ideal time, 1 or 2 months before, where you would want to suggest the patient changes in the diet so that if the blood sugar levels are good and he is fit enough to undergo fast, and also you would like to change the medications accordingly. Educational counseling does not just focus on the patient, but the family also need to be made aware about the symptoms of hypoglycemia and hyperglycemia. The meals need to be planned accordingly. The blood glucose monitoring system need to be kept in place. Patient's sugars, his physical activity, and also signs and symptoms, where we would tell the patient that you need to break your fast if you suffer from any of these symptoms. So the whole family need to be counseled and education need to be provided. So what are these categories? Whether the patient is at, if the patient is in category 1 where he is at a very high risk, I would advise the patient not to fast. He must not fast. And those patients would include if they have one or more of the following. If the patient has severe hypoglycemia, diabetic ketoacidosis or HSS within the first 3 months prior to Ramadan, if he has a history of recurrent hypoglycemia and hypoglycemic unawareness, if the patient has type 1 diabetes, if he has acute illnesses currently, if the patient is pregnant, patient is on chronic dialysis, or also if the GFR levels are very low in the stage 4 and 5, whether dehydration would push the patient further, if there are advanced macrovascular complications, extreme age with ill health, if the patient has cognitive impairment and uncontrolled epilepsy, these are the patient are at very high risk of complications and must not fast. Category 2 is a high risk patient where the patient should not fast ideally. If patient has one or more of the following, where the patient is type 2 diabetes with a sustained poor glycemic control, if the patient is a well controlled diabetes, but if he's on multiple daily units of insulin, the patient is having CKD stage 3 nephrotic syndrome, he has stable macrovascular complications, he has comorbid conditions that present additional risk factors, the patient with diabetes who perform intense physical labor, where the chances of hypoglycemia are higher, and if the patient is on drugs that may affect the cognitive function, because hypoglycemia can also worsen the cognitive function of the patients. Patients who are at a moderate or low risk and who may fast but with risk are patients who are well controlled type 2 diabetes and are treated with either only lifestyle therapy or are treated with oral medications which do not pose the patient into hypoglycemia, such as metformin, acarbose, TZDs, second generation sulfonylureas, incretin based therapy such as DPP4 inhibitors, GLP1, SGLT2 inhibitors, and basal insulin. So to confirm this, there was this study which was done, which was an EPIDIR study. It was a retrospective population study which was done across the world in 13 countries: Algeria, Bangladesh, Egypt, India, Indonesia, Jordan, Lebanon, Malaysia, Morocco, Pakistan, Saudi Arabia, Tunisia, and Turkey. And 12,243 patients, participants were analyzed, of which 8.7% were type 1 diabetes and the rest had type 2 diabetes. And nearly 43% of the patients with type 1 diabetes and 79% of the patients with type 2 diabetes, they reported fasting for at least 15 days during the Ramadan. And what was seen is that their physical activity, the sleep duration, the food intake, the fluid intake, and the sugar intake were not changed. And because of which, even the insulin dose, since it was not changed, there were severe hypoglycemic episodes. They were more frequent when the insulin dose remained unchanged in type 1 diabetes and even type 2 diabetes patient. Therefore, it is very important that the patient comes and changes the dose of its insulin and oral medications to prevent hypoglycemia during this month while fasting. So, what is the modification of physical activity and diet? Nutrition, you would tell the patient, advise him to avoid food which is high in fat and high in sugar. It is advised that the patient eats complex carbohydrates and proteins during the during the dawn, so that the patient sustains energy and the patient avoids hypoglycemia while he is fasting. And he can take simple carbohydrates at dusk when it is more appropriate when the patient is breaking the fast. On the other hand, we should also suggest the patient to have foods which have long glycemic indices when they are breaking the fast. Slow energy release foods such as grains, wheat, and rice are best before and after a period of fasting, so that they give energy to the patient for a long period of time. Intake of high fat, which is ghee and fried snacks, which is commonly taken at the break of the fast, should be minimized. Physical activity. So the common is a night prayer, which is Taraweeh, which is a part of the custom of the Ramadan, and it is a very long prayer. So the patients, which are men who normally walk to the local mosque, and they should be more encouraged to take such prayers, so that it is can be considered as a part of their daily exercise program, and the patient can continue normal levels of physical activity. And they can be, if they are exercising, they can exercise it in the evening rather than exercising during the day when they are fasting. So one needs to just change the timings of physical activity while the patient is fasting. For the treatment strategy, one need to understand that only medications which avoid hypoglycemia or are neutral should be given to a patient who is diabetic, and so that we prevent the patient from hypoglycemia. So an early initiation of a combination therapy is great to achieve the glycemic control. One, if the patient is uncontrolled, and it will delay the deterioration of the glycemic control and possibly preserve the beta cell function. So the combination of an SGLT2 inhibitor and a DPP4 inhibitor is suitable because it is safe, it has a rapid reduction in blood glucose level, and it also has a sustained glycemic control. It improves both insulin resistance and the beta cell functions. It helps to reduce weight and blood pressure. It reduces the pill burden because of the FDC which is available, and it turns out to be more cost effective. SGLT2 inhibitor, when prescribing, preferably to be advised when the patient is breaking the fast at the dusk, so that the patient is able to take adequate water intake post that, and it prevents the patient from developing any genitourinary kind of infections. Because in the morning, and if the patient is into dehydration, that will push the patient into further such complications. So, with this, thank you very much. I wish everybody a happy Ramadan and a safe Ramzan so that you prevent any such complications. Go to your doctors and get your sugars in control so that you're fit to fast and enjoy the feast during Ramzan. Thank you.
Rukaya, thanks for that fantastic presentation. I really enjoyed listening to you. And I think there were some very, very relevant points which you put across. You spoke about the risks of fasting. You spoke about, what kind of readjustments of medication is required. And I think most importantly, the most important message that you gave across is that yes, we need to make Ramadan experience a much more safer, a much more spiritual, and a much more easier experience for our patients. Rukaya, with newer data available, with so much more newer, with so much, so many more newer molecules available to us, do you think that that conventional thought process that we had, that, our patients, there is going to be some compromise in the glycemic control if our patients decide to fast? For example, I remember a decade back, we used to strictly tell our patients, no, you just cannot fast. Is it the same now, or you think the scenario has completely changed, Rukaya?
Yeah. So, Dr. Shaila, you pointed out really well. So a decade ago, the medicines that we had with us had higher chances of hypoglycemia. So we had sulfonylureas, which were great at controlling blood sugars, but yes, there were higher chances of them leading to a hypoglycemia, and we do not want any of our patients to experience that. Either the patients would leave the medicine or they would stop fasting. So we do not want either of it. And that's why now, thankfully, with the research, we have much meta molecules. We have DPP4 inhibitors and SGLT2 inhibitors, which do not give hypoglycemia. So they are safe. And the chances of hypoglycemia are very, very low. So we just need to stratify the patient. So it's no more a blanket statement that you have diabetes and you cannot fast. According to the diabetes, according to their control, according to the complications, we do certainly allow most of our patients to continue fasting. Few of our patients, we tell them, no, you cannot fast because of the high risk of complications and whether we would push them into hypoglycemia. Only then we avoid by adjusting the doses, giving them right advices, not just in medications, but also the diet changes. Then we are able to have a better glucose control. They do not have to compromise their glucose control if they are taking right medications and physical activity and diet, and they are able to smoothly pass the month of Ramzan.
I totally agree with Rukaya. I think it's very, very important that we stratify our patients before we make a decision about whether our patients can fast or not. And one very important point that Rukaya has brought across over here is because we have now better molecules with less hypoglycemia, you can make individual decisions regarding whether your patients can fast or not during Ramadan. And that would really help you as a clinician manage your patient better if you stratify them right at the beginning. The risk stratification score is very, very clear about mild, moderate, and high risk. And it is not only a medical obligation for us to actually stratify the patient, but also, to be very honest, a spiritual obligation. Because if you say, as a clinician, that you are at high risk and you are allowed not to fast, this is actually been accepted even by the religious authorities. So I think as clinicians, it leads to a lot of responsibility. And when you are making the decision about whether your patient is going to fast or not. Rukaya, when you spoke about the risks of fasting, I mean Ramadan fasting, it's always been when you talk about hypoglycemia. What message do you want to give regarding what kind of information do we give our patients regarding hypoglycemia, and when do they break their fast? Is it only hypo? Is it hyper? How do they go about it?
So it is very important that one needs to understand that even if the patient is fasting, he definitely can check his blood sugar levels. The patients do not, the fast does not break on checking blood sugar levels. So the patient can check their blood sugar levels. So a mid morning time in the evening and before iftar, and also after 2 hours after iftar are the times. So before iftar is the time which gives you a fasting blood sugar level approximately, because the patient has fasted for 14 hours and you see whether the patient's blood sugar levels are in control or they are out of control. So that is point number one, that you tell the patients that even if you're fasting, you need to check your blood sugar levels. Point two is that we are worrying about hypoglycemia. We need to educate our patients about the symptoms of hypoglycemia. So it's very important to tell the patient that you may feel excessive sweating, you may feel tingling, numbness, you may feel, he may experience those giddiness, and he needs to check the blood sugar level. If the blood sugar level is less than 70, he needs to take, he needs to break the fast and he needs to have some sugar. If the sugars are between 100 and 120, the patient can check the blood sugar levels again after 1 hour and see whether the patient, if the blood sugars are not falling down further, he can continue with the fast. Point number three is that it's not only hypoglycemia. During fasting, the whole mechanics in the body changes. The way we utilize our glucose, we are using our glycogen reserves, and that changes completely when the person is fasting for a long period of time. So it is not only hypoglycemia, the patient can also be pushed into hyperglycemia, because the patient is not using glucose. It is the glycogen in the body which starts breaking up. So more the glycogen reserve starts breaking up, there is increase in hyperglycemia. Then the ketone starts rising, because there is less insulin being secreted in the body because there is no sugar intake. So with the decrease in the insulin and with insulin being absent in the body, the ketones levels start increasing. So the patient would commonly feel dizzy, and he may start vomiting, having nausea. So, if the patient has such symptoms, that is also worrisome, and the patient needs to check the blood sugar level. So, it is both the extremes, not just hypoglycemia. Hyperglycemia can also be very dangerous, and the patient needs to break the fast if the blood sugars are high.
I really appreciate the fact, look, that you brought hyperglycemia in the picture. Because when we talk about Ramadan, we often think about hypoglycemia, but we don't realize how much of feasting is a part of Ramadan. Not only do you see the hyperglycemia as a result of the feasting in Ramadan, you also see hyperglycemia because a number of, there's sometimes overcorrection of the reduction in the medication. Your patients may reduce medication on their own a little over enthusiastically because of the fear of hypoglycemia. Sometimes the reduction of insulin may be more than what is required, and at that point of time, also you may have hyperglycemia. I mean, this is exactly what Rukaya is trying to tell us. Rukaya, I wanted to understand from you is when you are educating a patient regarding, hypoglycemia or hyperglycemia, do you think it's very important that we also educate a family? Because
Absolutely.
often what we have seen, yeah, I mean, because often what we see is, it's not only a single patient, but an entire unit which needs to be educated regarding. What do you think we should be doing during pre-Ramadan education?
So one needs to educate the family about when it is not normal and the patient needs to be tested, and they also need to be educated about that Ramzan is not just about feasting. There has to be certain changes in terms of their food because the patient is diabetic. So you cannot have the same kind of a dinner menu for a person who's diabetic and non-diabetic. A diabetic person, if he's fasting, does not stop his diabetes because he's fasting for 14 hours. At the end of the day, he needs to eat healthy food. He needs to avoid high fat and sugary drinks that needs to be taken. So one need to make sure about that. So that's why educating the family helps them to plan the meals for a person who's diabetic. So that goes hand in hand where the patient is able to carry it out safely.
Thanks for that, Rukaya. I really appreciate that because I think it's very important, especially when you are having iftar. I mean, we all know iftar is not only, if it's not a meal in isolation, it's actually a social occasion. I mean, iftar parties, I think, are something which we are already beginning to talk about. Dates are being blocked that, okay, when, who is going to give what iftar party? That's the discussion which is happening the rounds at this point of time. So, I mean,
Right.
when you are talking about iftar, Rukaya, what guidance do you give your patients regarding their diet? What kind of diet? We talk about the Ramadan plate. Do you think an entire household should start consuming a meal according to the typical Ramadan plate?
That would be ideal. If the family is in it together, it's ideal. But I think all the, with the iftar parties getting blocked, there are also menus and recipes which are getting circulated, that these are some latest recipes which one wants to, try it out for their family in this. So it's more about, so that's the spirit of the iftar party, that it's more about the social occasion, it's more about meeting and greeting and praying rather than feasting. So when one understands the essence of it, then feasting is just, the food is only a byproduct, right? It's about meeting everybody and enjoying the company and eating that. So Ramadan plate, if everybody in the family is really going to follow it, it would be so easy for a person who's diabetic to not feel left out. See, it is very, it is, I feel, he really feels bad at the end of the day that I am not allowed this because I have diabetes. So we need to understand that, and sometimes I just tell them you can enjoy it, but the portion control is important. So you can have the same food which is made in the house. Of course the whole food is also made, so you can, the fatty foods you can just have like a piece of it. Instead of having five bhajiyas, you can have one, right? So it is about, you don't have to feel out of place. You don't have to say that you need to make things different for me. You can control your portion. What I'm commonly giving advice currently to my patients is that, because it's also very hot and summer is around the corner, chas, chas would be really great as a evening drink when you're breaking the iftar, and that would hydrate the patient, give the patient some protein also along with it, and make him feel satiated because of the protein in it. So that is one of the options that I am giving to my patients as the drink. Madam, sharbat nahi piyenge to how will we break the fast? So khajur is allowed. I tell them you have one or two pieces of khajur because you're fasting since morning, your blood sugars are at the low. That is fine because it has fiber also with it. But yes, the sugary drinks can take a back seat.
Accepted, totally accepted. Rukaya, when you were talking to us, you also spoke about exercise. You spoke about Taraweeh prayers. Now, when our patients are into any kind of exercise regimen, or if your patients are, for example, going for a walk, what would your advice be? Or is Taraweeh prayer going to suffice as the exercise regimen? But in a number of households, especially the ladies, do not actually perform the Taraweeh prayer. So, what would your advice to be to our patients who are going to be regarding the exercise regimen?
So I tell them that if you are always been walking, you may continue walking, and that should not be a problem. You take, if you're on a moderate physical intensity workout that you do, then one needs to do the physical activity in the evenings after iftar rather than doing it while you are fasting. And Taraweeh prayer is not sufficient for a daily activity, but it is not sufficient, but that just motivates the patient to be more physically active, because the big feast after iftar, patients tend to be lazy, lying around, and they don't have any activity. So Taraweeh just helps them to get their metabolism in place, and it just helps kind of, if I tell them to go out for a walk with 2000 steps also would be difficult. So at least, with the spiritual thing, they go out to perform the prayer. So for the men it becomes easy, for the women it would be nice that if they do it, and otherwise if not, at least go out for a walk after iftar and make sure that you are walking during the day as well, that you're continuing. One doesn't have to stop everything because they are fasting, they need to continue what they are doing.
I agree with you, Rukaya, but to honestly tell you, after after breaking the fast after iftar, I also turned into an absolute lazy person. So I can really relate to the fact that most of the patients really don't want to do much, and I think Taraweeh is a great motivating factor to get patients back on their feet, because they know that after they've sort of taken their iftar and after they finish their mandatory prayers at that time, maybe after 1 hour they have to go back to pray, because as Rukaya is saying, that Ramadan is not only a question of fasting, it is also not a question of feasting. It's a question of sort of a lot of spiritual enhancement and sort of trying to evolve spiritually, which involves a lot of praying, and that's the reason why Rukaya, sleep is often altered. One of the biggest issues that we see in our patients is alteration of sleep. The number of patients will be sort of staying awake in the night to most probably pray, or in the day also they are praying. So, do you think this alteration of sleep, there's some advice we can give them regarding their sleep patterns?
It would be ideal if they go off to sleep at 11 and then wake up, but that doesn't happen commonly. Most of the patients would continue to stay awake, or they sleep so late in the night that they do not get up for the dawn, for the seri. So this is one thing which I'm very strict about, and insist the patient that if you're a diabetic, you need to have your seri. You cannot skip your seri because you've had a long, lengthy iftar and the party and the late night eating, which is going on and on. So that's why seri is very important, so that the day is fine. Um, it it would be great if the patient gets the night sleep, but if he doesn't, then he can divide it into 4 hours at night and then 4 hours after 7 till 11. So we still try to balance that and try to get it, but we know that even for hormone wise, it is ideal that the patient gets the night sleep to have a better metabolism in the body. You have any tips for it, Dr. Shella, how to help them with
I totally agree with you, Rukaya, because the circadian rhythm is influenced in a very big way when we alter our sleep patterns. And I think
yes.
the lack of sleep, or the the sleeping which is broken sleep as you would call it, or this reduction as far as REM sleep is concerned, is what contributes in a very big way to some of the variability that we see in our patients who are fasting during Ramadan. I think some of the glycemic variability contribution is because of the irregular sleep patterns. And as you said, ideally that is what we want to do, but as we both know, it doesn't happen in Ramadan. Most of patients would sleep late. Most of the patients, after they finish their morning prayers, because even after they've had their suhoor, we need to understand there's a period of time when they're going to be praying, and then most of them will sleep. So it is a little, a totally different way in which patients would be looking after themselves during Ramadan. And that's the reason I always say, look, we need to understand what the patients are doing. For example, some patients will have a heavy iftar and a light dinner. Some patients have a light iftar and a heavy dinner. Some patients, as you very rightly said, maybe have a heavy dinner at 2 a.m. in the morning and go to sleep, which, to be very honest, number of patients I know do that. Or some people will sleep early, and so it's a very variable pattern you see. And we need a lot of individualization out there, and that's the area where pre-Ramadan education really comes into play, where you understand these patterns better. Okay, in the
we
interest of
need
time, I'm going to ask you the last question of the day. Though I know the session can go on and on and on, I think we'll have to be given another maybe 2 episodes before we actually finish talking about Ramadan. But coming to the last question of the day today, um, Ruqayya, how do you think medication should be adjusted? Insulin, for example, for example, OHAs, which medication, which medication you think really needs adjustment during Ramadan, and how should your HCP look after those adjustments?
Okay, so the most common medications, metformin can be continued as they are, and the afternoon dose, if it's there, then that can be combined with the evening dose in an extended release form. So if the patient is taking 3 times a day metformin, he may have it twice a day, and the evening becoming an extended release form. If the patient is on sulfonylurea and it's a twice a day molecule, then one need to reduce the dose at seri. It needs to be reduced by 25 to 50% in the morning, and dinner can be consumed in the same way. DPP4 inhibitors and SGLT2 inhibitors, one do not need to change the dose of it, but we just need to alter the timings. Especially SGLT2 inhibitors would be only in the evenings and avoid giving them in the day, so that the incidence of genitourinary infection with reduced water intake, you do not want that. Coming to insulin, so since the patient is taking heavier meal in the night and a smaller meal in the morning, so if the patient, you need to reverse, the morning dose can become the evening dose, and the evening dose becomes the morning dose. Also, one needs to reduce the morning dose by 25%, so that the patient does not develop hypoglycemia. So this is how I do it. But like you were talking it, one needs to individualize it. So if the seri, if the iftar is light and the dinner is heavy, so the sulfonylureas go before dinner. If the iftar is heavy, then the sulfonylurea will be coming at the time of iftar and not at the time at dinner. So in between, also between iftar and dinner, some patients have a gap of 2 hours, some have it all together, and some have it at a long period of 4 hours gap. So that can also needs to be changed and needs to be individualized according to the patient. Overall, basal insulin can be continued with the same dose and does not need any change. But pre-mixes, the morning dose needs to be reduced by around 25%, and that can just suffice the blood sugar control.
Thanks for that fantastic overview, Lukaya. I'm sure it's going to help a number of our listeners. And I think one very important point which I would also want to add over here is that whenever you are readjusting medication, please request your patients to monitor. Please request
Yeah.
your patients, especially when your patients are on SUs or insulin. It's very important that your patients monitor their sugars. Ideally, we are supposed to monitor a patient's sugar 6 to 7 times, but it often doesn't happen that way. So we request our patients at least to monitor, as Rukaya said, before iftar and 2 hours after iftar, at least basic, so that we understand what is their pre-meal situation and what is going to be their potential post-meal 2 hours post-meal situation. We often learn one question which patients ask us, ma'am, if I want to monitor my sugars, what would be my fasting? Your fasting would be before you break your iftar. And depending upon what kind of meal you're consuming, whether you're consuming iftar or dinner, post meal would depend upon that. And accordingly, you can monitor your patient's sugars. Because if you do not monitor, you really do not know how your patient is responding to all these changes that you have made. And in order for you to be able to really prevent hypo and hyperglycemia, both you need to monitor your patients. Thanks, Rukaya. Thanks for that. I
Thank
think
you.
it was great learning from you. And it
It
was,
was
I'm sure
great.
everybody who's logged on is going to benefit from this fantastic session that we've just had over here. Wishing each and every listener out there a very, very happy Ramadan. And over
Yeah.
to you, Rukaya, for the last word.
Thank you so much. It was great. I enjoyed having this conversation with you and wishing everybody a safe and an ideal A1C during Ramadan, and no hypoglycemias and no hyperglycemias. And please remember us in all your prayers. And with this, I think yes.
I think the last part was the most important part. Thank you very much. Have a great evening. Signing off.